this, the feel-good topic of the year, opioid addiction. A couple facts, which, you know, again, they've been like blasted across all headlines. It's bigger than any celebrity these days. Roughly 25% who receive a prescription opioid for pain relievers will abuse them. 25% who just prescribed will end up abusing them. Opioid overdoses have become so common that they are the #1 cause of injury-related deaths in the United States. I'm constantly astounded by those numbers. Even though I wrote them, I'm still astounded by them. So this next session, which I'd like to invite up while I'm talking, is led by Dr. Itai Danovich, the chairman of the Department of Psychiatry and Behavioral Sciences at Cedars-Sinai Medical Center. They will discuss the spiral to addiction, how technology can aid in stopping it at the source, and what innovations might provide the treatment needed to end this tragic crisis. Let's welcome them in this power panel to the stage. Thank you.
Great. Thank you very much for the introduction. I'm going to make some brief introductions of my own and then quickly get us started with with a conversation, series of questions that I'll pose to our panelists to address. So as you've just heard, drug overdoses are the leading cause of accidental death in the United States. The numbers are just staggering. I mean, you'd have to live on an island with your head in the sand not to have read all the headlines about what's going on. But 52,000 deaths in 2015 alone, 500,000 deaths over the last 15 years. And even more strikingly, what's often not talked about is that for every single overdose death, there are over 160 people that report having addiction and 460 people that report misuse of opioid analgesics. So a really profound problem. Further, it's also been estimated that about 50% of adults in the U.S. have a 1-degree connection to somebody who has been directly impacted by the opioid epidemic. So I won't ask you and the audience to raise hands, but my guess is that half of you have been impacted, and that this is not just a societal issue, it's a personal issue of great, great import. So what's been the response? This is unfortunately, one of the few areas where we've had kind of bipartisan agreement and action. The Surgeon General, the CDC, the FDA, multiple consensus bodies have come out and acknowledged that this crisis is an epidemic. And a whole series of initiatives and strategies and funding mechanisms have been established to help stem the tide and have an impact. And they have had an impact. I'll say one other thing that's remarkable about this drug epidemic in comparison to other drug epidemics is that unlike other drug epidemics, one, not the only, but one of the significant drivers is physician prescribing. And through a series of intervention, there have been some curbing of physician prescribing of opioids, but the death toll continues to climb for many, many other reasons. And we clearly have a complex problem that continues to evolve. So the central, we have 30 minutes to discuss a topic that whole conferences and initiatives are devoted to address. But this is a bold conference, and we have a bold panel of incredible physician leaders with different perspectives on this space. And the theme that we're going to be addressing is how to move beyond kind of incremental change and marginal improvements to really disruptive and profound impact on this epidemic. Okay, so to introduce my panelists, we have Dr. Shai Gozani, who's President, CEO, and Board Chair of Neurometrics. This is a medical technology company that develops innovative wearable devices and point-of-care neurodiagnostic services. He holds a master's degree in electrical engineering and computer science and neurobiology, a PhD in neurobiology from Berkeley, a doctorate from Harvard Medical School, and he's been awarded over 25 international patents for his work. We have Dr. Dick Migliori, who's Executive Vice President of Medical Affairs and CMO of United Healthcare. He works with businesses across his enterprise to improve healthcare quality, access, and affordability, and also serves on an innovation council and has spearheaded the design, organization, and management of national healthcare delivery networks. And we have my friend and colleague, Dr. Brennan Spiegel, who's Director of Health Services Research at Cedars-Sinai Health System. He directs the Center for Outcomes Research and Education and directs a team that's involved in a wide degree of activities. Brandon's an educator. He runs a master's program. He's an inventor. He has a company that has developed a wearable device that monitors digestive activities, abstats with it. And he's a scholar, publishing academic with federal funding. And finally, he's impervious to pain because he's a marathon runner. You know.
Some truth to that.
Okay. So let me start by posing a really easy question to each of you one by one, which is, if you had no resource constraints at all, and you could do one thing to make an impact on ending the opioid epidemic, what would it be?
Start down there.
Shai, do you want to take a first stab at it?
Can I answer a slightly different question? Let me repose. I think that you addressed it. I think the complexity of the challenges in the broader opioid crisis probably defy singular solutions. But if I were to have to identify one change, rather than an intervention, I think a philosophical change where we think about treatment of pain, not in the narrow sense of just decreasing pain intensity, which has really been the focus, but to really decreasing suffering and disability as relevant to the individual patient. And I think if we broaden our perspective to the goals of treatment, then I think our use of opioids will change and become more appropriate. But I think that philosophical change has to take hold, both at the level of the healthcare system and also the expectations of the patient.
Dick?
You know, you look at this problem that'll kill 184 people today, and we see it as our role is trying to do two things, one of which is to prevent the next person from becoming somebody that's exposed to opioid use disorders. And then the second thing is to rescue those who already are. Three things are there to do, one of which is manage the prescribing behaviors. Second is to provide alternatives to pharmaceuticals for the treatment of pain, because the pain is real. And then the third thing is the rescue programs, helping people do things that follow the American Society of Addiction Medicine's guidance in terms of the most current science in doing it. But if I had to put my money on one thing right now, I think the biggest issue would be influencing prescribing behaviors. If you look at the 4 million people in this country that are addicted or have a use disorder, 70% of them are getting prescription drugs that were prescribed for another individual. In other words, it's diversion. And one of the things that we have to do is to be able to get a better handle on how much drug is available out there. So the application of technology, it's really providing the physician with tools in their hands that they can use in the office to help them follow CDC guidelines for the prescribing behaviors, to look for alternatives for pain management. But the third thing is also to take advantage of the prescribing databases that are out there that have been built in all but one state in the country that have the ability to show a physician what other medications related to narcotics a patient has been prescribed, so that they make more informed decisions. And when you do those kinds of things, and when we've put in those kinds of capabilities, we've seen a 72% reduction in prescriptions that had an excess number, or that had excess dosing in it for first time around prescriptions. It's very powerful.
I agree with everything that Dick just said. And I think the question is hard to answer because there is no one thing that can solve this epidemic. In fact, the language that we use in conferences like this, in digital health science in particular, is we've solved for X or we're solving for Y. We can't solve for this problem. This is a complex biopsychosocial problem. Pain is a biological phenomenon. It's a social phenomenon. It's a psychological phenomenon. And to make inroads in something of this complexity requires a multidimensional approach. And we just heard the outlines of that approach. And I think over the course of the next 20 minutes, we might start talking about specific examples of technologies that we're all using to try and triangulate in on this problem. So there are all sorts of arms and legs to this problem. That means there's great opportunity for innovators and developers to figure out where they fit into the conceptual map of solving this problem. But the idea of one thing kind of being a magical key to unlock an epidemic of this size is sort of a fallacious starting point. Not to critique the question, but I think that's my reaction to the idea of we're going to fix it with this or that. We can't possibly think of one thing that will do it. It's going to be complex.
What do you think are some of the most significant barriers to implementing some of these ideas? The ideas are compelling. There's indications that they work, but what is getting in the way of our disseminating and implementing them in a way that touches the people that are affected?
Maybe I'll start. We'll go back in the other directions, and I'll just keep rolling because I think we've heard a little bit about this. This is in part the result of physician behavior and, of course, patient expectation and patient behavior. So ultimately, it comes down to the dyad, the prescriber and the patient. And what is the process of care, the process of decision-making that is occurring at the point of care in the clinical trenches when a prescription is yielded? We have to break down, understand the architecture, the anatomy of that discussion, and figure out where we can intercalate technologies or approaches to disrupt that very specific conversation. So it's complex, but from you asked what are the barriers? Well, I'm a physician. I see patients in the hospital. I'm busy. I have patients in pain. I often think of it as a biological problem. I need to fix the pain, and opioids will do that quickly and efficiently. Patients will be comfortable. I'm not going to get phone calls. And the barrier there is just the efficiency in which opioids work to provide the immediate analgesia that I need. But we're sowing the seeds of dependency in the hospital. People are being discharged from the hospital after an operation, and all of a sudden they've never seen opioids in their life, and they're being discharged with opioids. But that's not my problem. If I'm in the hospital, I've done my job, and out they go. So the barriers are just the simplicity and the efficiency and the effectiveness of the drug, and trying to understand how can we stop that by interposing virtual reality or whatever else we'll talk about today to sort of nip that in the bud before we sow the seeds of dependency.
So let me just ask you one follow-up before moving to Dick. I know you have a study looking at this question, a study evaluating different communication techniques between patients and physicians in primary care, funded by PCORI. But it's taken you a long time, right?
Yes.
The funding cycle, right, to get federal funding and to study in a robust and scientific way these questions is a long time, and yet we have an ongoing and emerging crisis. Are there other mechanisms that we should be looking at to have more rapid cycle innovations and developments and learnings and insights that we can bring? Is that the right?
Well, yeah. I mean, we're fortunate at Cedars-Sinai, as you know, to have a health tech accelerator in partnership with Techstars. So this is a much more efficient and effective way to bring in companies. We bring in 10 companies every 10 months that align with our operational needs in a hospital system. And if the opioid epidemic is one of those operational needs, we can bring in companies like Applied VR, which develops virtual reality interventions, to work with them quickly. We don't need to wait for NIH funding cycles or PCORI funding cycles. And in the process of doing that, we've published 4 or 5 papers. You've been a part of one of them, none of which are federally funded, just moving forward quickly. We still need federal funding, and we have a PCORI grant, as you mentioned. We could talk maybe more about the specifics of that. But the answer to your question is there's different ways of accelerating the timeline.
Yeah, Dick?
The point that you made earlier about, I agree with it, this is an issue that in no small part relates to physician behavior. But the behavior that we're talking about was one that was driven by compassion, but also driven by regulatory agency as well as Joint Commission work, et cetera, that was looking at pain as being the 5th vital sign, and in fact looking at means by which you're saying that the drugs were assumed to be safer than they were, and physicians were being chased to make sure that they were providing enough. It wasn't until March of 2016 that there were real scientific guidance about how to use these powerful agents effectively. And so you come down to the issue is how do we change 1 million prescribers' behavior at once? And that's why I think where it's not only that technology makes it better, I think technology is now an imperative. You've got to be able to provide the physician with the decision support platform that allows a busy physician who's dealing with somebody with pain to be able to respond quickly, but in evidence-based fashion. The ability to look at the guidelines, put the right type of drug at the right time for the right reason is important, but also to be able to do things that a physician isn't really able to do, which is to be able to go purge and query other databases that may have an influence about that specific patient. And you're starting to see the emergence of some of these handheld technologies that are designed to do that kind of thing. And so I think it's encouraging that we have technology, and the adoption rate will be faster, but it is a matter of changing behavior. But this was not malbehavior by opportunists. These physicians were driven by compassion and being prodded to get there, and we could reverse that.
So, I think I would agree with both my colleagues. I think we can look to the consumer, the pain sufferer, as a potential direct player in the process. Many of these technologies that we're talking about, whether it's in our case neurostimulation, virtual reality technologies, digital therapeutics delivered via mobile platforms, those are inherently safe approaches that have fairly low regulatory barriers, relatively speaking, and in many cases, our case and others, can be directly provided to the consumer. And that's a very, very rapid channel. The consumer, the pain sufferer, has an inherent motivation. Often they recognize the concerns. They're very concerned with their own personal issues around opioids, or their family members who may be touched, as you suggested. So I would look as part of the solution to direct to consumer. We have seen that, and that's our approach. We actually started out as a prescription device, trying to go through the traditional channel of getting a prescription device into the hands of patients, and found it to be very difficult. And when we switched to, after getting FDA clearance to do so, to the direct over-the-counter approach, we're really seeing the process facilitate. So I think we can leverage the direct-to-consumer channel because technology is inherently safe. There really are very few downsides to taking that approach.
Mm-hmm. Mm-hmm. Let me ask you, how many of you in the audience are healthcare providers? Some of you. So let me ask a follow-up question to that, to just unpack some of what happens when somebody's, for many people, their first exposure to opioids occurs after an incident where they have acute pain, and they're looking for immediate alleviation from that suffering. And historically, one of the things that doctors have reached for that's incredibly effective in the short term is an opioid analgesic, an opioid medication or drug to alleviate that suffering. All right, very effective in the short term, very problematic in the intermediate to long term. What are some other options or choices that physicians have or that patients have to choose from in that setting, Shai?
Well, yeah, I think we've touched on it. They are extremely effective in acute or transitory pain. And physicians, Brennan really identified this, they really don't have the time for some of the other interventions historically, which are complicated to deliver. And I think this is where technology increasingly can bridge that gap. So if Brennan, you're seeing a patient and you can prescribe an app, that maybe delivers cognitive behavioral therapy effectively and is proven in lieu of an opioid, then you would do it. But you don't have those options. I think that's emerging. Clearly, opioids have a role. There's no doubt about that. But I think technology, if we can get the technology-type therapeutics to the point where they can be used easily and effectively and proven and gain the confidence of providers, then I think they can slot right in and start to take up some of the role that opioids have had.
Uh-huh. Brennan, I know you've had some experience giving people a device when they're in the hospital with acute pain and watching what their reaction has been.
Right.
Can you share that experience?
Yeah, so at this point, we've treated almost 2,500 people with a therapeutic virtual reality at Cedars-Sinai, principally for pain, for other conditions as well, but pain principally. And it's a compelling thing. It's a compelling thing to see somebody try a technology that impacts their well-being so quickly. And that's a whole separate session. What is the mechanism of VR and so on? We can maybe talk about that, touch on it today. But when it works, it absolutely works. I've seen it firsthand. We have videos online of our patients, because I could sit here and talk about it, but to see our patients experiencing virtual reality, and in some cases crying tears of joy that they finally have been unlocked of their pain, even if it's just for a short period of time, it's amazing. I've had people who are on a ketamine drip, very powerful sort of modulator. It's a very kind of interesting medicine where nothing else worked, and virtual reality worked, and the patient actually went home the next day. I think the problem, the hard part about this is not finding the next technology. It's the implementation of that technology. How do we actually get it into the hands of patients? So what we're working on now is how do we actually put virtual reality, for example, and there are others we'll talk about, into an order set. If an orthopedic surgeon is about to do an operation, how does he or she order virtual reality? So we've developed a virtual reality consultative service. We call it the Virtualist. And that's our job, is to go and tailor the VR experience to that individual and prescribe it. Tailor the therapy to that individual. And we have to have those kinds of resources now to start implementing these alternative therapies at the point of care, rather than just sort of dropping it into a room and hoping and crossing fingers that it's going to stop opioid usage. That won't work. We need to have techniques and protocols now.
Dick?
Yeah, along these lines about influencing the perception of the need for pain, a couple of quick stories. Number one, there's some pretty good academic literature around people who break their hip in the Netherlands. Their likelihood of going home with a narcotic is under 3%. If you break your hip in this country, your likelihood of going home with a powerful narcotic is about 85%. And so there is things about expectations. One of the things that we did was to look at 2 million Americans that had back pain. And we tracked their use of narcotics based on who was the first clinician that they saw. And one of the things that we saw, we have a network of some 80,000 physical therapists and chiropractors and the like as part of the 1 million physicians that we have. And one of the things we saw was when they went to a chiropractor or a physical therapist, the likelihood of getting a narcotic at any time in the future for that episode of back pain was under 5%. If you go to, if they went to any of the other specialties, the number was around 13.5%. So you can see there's rather significant differences in setting up the expectations. The type of technology to help them, dying to see this virtual reality, because that could be a big thing, especially as I'm looking at hip surgery pretty soon. But the other side of it is also the stuff that does the ongoing support and showing people how to do it, because people have to work at it if they're going to start taking these physical medicine approaches. But when you do, they're very powerful.
It's one of the factors that I think you're speaking to. There's underlying societal factors, both in terms of expectations and, to some extent, many of the determinants of health are social. But particularly for the opioid epidemic, and areas that have been hardest hit are areas that have suffered from other psychosocial or economic disparities. With your role in a health plan, overseeing this, being responsible for the medical side, but bearing the burden of what's happening on the societal side, how do you manage that? And what's the role of the kind of health provider community in addressing these major social determinants?
We're pretty fortunate in the types of assets that we have at United Health Group, because it's not just benefits, but it's also medical services that we can bring in, like behavioral health for people who are addicted, pharmacy management, the analytics, et cetera, that we have, helps us put some of this stuff together. But if you look at the people who are addicted, our eyes were opened up when the healthcare law changed, because we had a change in coverage from people who were 20. You could be on your parents' benefit plan up until age 25. With the change in the law in 2010, We moved it just 1 year to 26, all right, and that became the law. What we discovered was that 1 year was full of people who are unable to be employed because of chemical dependency, and our chemical dependency use rates went sky high. Heard the at testimony in front of the President's Council, I heard the Secretary of Labor said that for the population of men who are unemployed, that 44% of men who are unemployed between the ages of 18 and 58, 44% of them had taken an opiate within the last 24 hours. And so you start looking at these things, you start realizing it. You also start looking at the group that's being affected. These are kids. These are people 18 to 29 years old. That magic age of 28, we know all these rock stars dying. It is part of the way in which their brain is wired. But as you start looking at that group, you know, a bunch of them have coexisting psychiatric diagnoses. Others have had childhood traumas that are being masked. And the final group are people who are impoverished. If you don't handle those issues, you will not get to the base of dealing with that. And many of these people have never had a medical reason to be on an opioid, but they were getting access to them for the problems that we talked about earlier.
Shai, you spoke to the challenge of getting, or the opportunity of getting devices and technologies in the hands of consumers. Right, consumers right now, patients are sometimes coming to the medical system with an expectation and desire to have relief through opioids. How do we get these devices and technologies into the hands of consumers? How do you activate consumers to play a different type of role?
I think from that perspective, we're in a good place because actually, many consumers, they understand the risks of prescription opioids, and they're looking for alternatives. So they're educating themselves. Not all, but many. So I think the word is getting out, and I think at one level, just educating the population about the risks and about the alternatives is very effective because they will then take the initiative to find alternatives. I think if the broader healthcare system has to adopt these technologies, they have to pay for these technologies, the regulators have to approve these technologies, and I think that's coming along. I think we're at a point right now where on a net basis, I think the healthcare system is inhibiting adoption to some degree, but potentially properly. Because I think the clinical effectiveness and cost effectiveness are still being determined. But I think, and as we move forward here with better quality clinical studies and more cost effectiveness, economic type studies, I expect that to start to change.
So I know, Brennan, you had a follow-up to that, and you also sparked another question. So let me let you take the next.
Yeah, I'm fond of saying, if you were to look at my Twitter feed, my sort of top tweet is that digital health is not a computer science. It's not an engineering science. It's a social science. It's a behavioral science. So what I mean by that is it's become relatively trivial to create the technology. The challenge is implementing it, is getting it into the hands of people, and then measuring whether it's working for those people or not. And that's what we do. I'm essentially a social scientist at heart. So we have a new study that we're very excited about that's being supported by Travelers Insurance, together with Bayer and Samsung and Applied VR. And this is a group of different companies that all have in common a desire to make inroads into this epidemic. And what we're doing is a randomized controlled trial of patients who have had acute musculoskeletal injuries, just those people who are at risk of being put on an opioid when they don't need it. They're opioid naive otherwise. And we're going to be randomizing them to usual care versus a pain reduction kit that we actually mail to their home and shows up with instructions. It has a TENS unit that Bayer has developed. It has software from Applied VR, a VR headset from Samsung, and also a smartwatch from Samsung. And we're going to have a digitalist, a digital navigator, a clinician who actually works with those patients from afar, monitors them, and navigates them through the first 2 weeks to try and do everything we can in our power to keep them off of opioids while maintaining their pain control where possible. It takes a full court press like this with a lot of participants, a lot of science, and a lot of resources to really answer the question of how do we get this in the hands of people and measure if it's going to work. So hopefully this time next year, we'll have some results from that study.
Great. And Shai, I think you were speaking to also some of the challenges around the coverage of services by health plans. So I want to, kind of put that to Dick in terms of how can we, is there an issue there, and how do we help health plans kind of cover be innovative in covering products or services that may be helpful, right? 'Cause to reframe that, physicians are often, and consumers most likely to use what's covered through their benefits, and benefit structures sometimes have a long kind of legacy to them and it takes time to change them.
This is a particular area in which I think health plans have evolved, and if they haven't, they better. All right, we got a problem now that left to its own devices is deadly. We need to be able to spark innovation. Now, what we can't be is in a circumstance in which we're just paying for anything that hits the wall. So what we've done, and we've done it historically with like bone marrow transplants for breast cancer, like you carve money out, you carve out an environmental test market, and you allow people to experiment, using all the good scientific protocols, so you're really looking at legitimate science as it's being developed. But you just heard travelers here, making that kind of investment. Those are worthwhile, low-cost experiments, and they're promising. And when those kinds of results come back, and you've got to look at them for the impact that they have, then we can rapidly drive their adoption. In fact, the perspective that we have is that as a health plan business, or even as a health services business on our Optum side, we can make the current capabilities as efficient as they can be, but they're going to be limited based on the life science capability of that intervention. True changes in healthcare are going to come from the life sciences company, including my two colleagues on each side of me, who are going to be able to show that we can make a change in the trajectory of a disease progress. Then what we can turn to do is not only make sure they're covered, but also drive the adoption with all the other capabilities we have at changing consumer and physician behavior.
Let me just do a quick time check. Jill, how are we doing in terms of time?
Looks like we have it right here.
Oh, okay, great. Thank you. So one of our, so there is a need and opportunity to discover and develop new ways of tackling this problem. But you've also referenced that there's a lot that we know how to do that we don't do. There's a lot of well-established evidence-based practices, psychosocial interventions, therapies, we have problems with access, we have problems with quality of care, we have problems with helping consumers be able to benefit from the interventions we already know to be working. How do we use the concepts of innovation and technology to help reinforce and deliver and disseminate things that we already know to work? Brennan, do you want to?
I'll just touch on an example, which you're aware of, and there's that PCORI study, so the Patient-Centered Outcome Research Institute, as part of the Affordable Care Act legislation, supporting a study right now where we're just trying to answer this question of can we get doctors tools so that they follow CDC guidelines? We know what best practices look like already. Before we get real fancy, can we just try and follow those guidelines? Can we provide tools, as my colleague said earlier, to doctors and patients in the clinical trenches? So what we're doing is using our electronic health record, using best practice alerts and clinical decision support to engage patients at the point of care with their doctors, to remind the doctor to fill out a pain contract, to print that physical contract out electronically, which is an idea of yours, in fact, to come out there and talk about it and fill it out and document it, to electronically send patients educational information to set expectations before they come and see the doctor simultaneously providing the doctor with information about the total morphine milligram equivalents, or MMEs, that that patient has seen over the last period of time. These are tools that can be integrated right now at the point of care, but aren't. And what we're doing is a randomized controlled trial, which you're a part of, to actually see if this intervention improves outcomes, a variety of different outcomes, including, by the way, the patient's experience of their pain. It's not good enough just to say, oh, we stopped opioids. Well, that's not good enough. We also have to demonstrate simultaneously that their pain is the same or better than the group who is exposed to usual care. It's not good enough just to say we stopped the meds. So it's a complex problem. This is one of the ways we're trying to approach it, just starting with the basics.
Well, unfortunately, we are out of time, so we have to make that the last word. We could keep going on this. I want to thank my really distinguished panelists for presenting your ideas and this discussion with us, and I want to thank you all for your attention to this important subject. So thank you.
Thank you, guys. Thank you.